We'll go ahead and get started with the afternoon session. For those of you who ate the cookie, you got another 5 minutes to add to your 30-minute walk this afternoon. So Dr. Newhouser is going to watch every one of you. So this the next session is really focused on. Oh, we got a question back there. Can you hear me? The next session this afternoon is focused on advanced prostate cancer. We have two talks that focus on new ideas around using genomics as well as androgen testosterone therapy. And then we'll move on to our two keynote talks. Same format as the morning. We're going to be holding questions until the end of all of those talks, and then we actually have a half an hour allocated to be able to ask the speakers various questions. So write your questions down. We have more cards if you need them. Don't be shy. So our first speaker for this afternoon is Dr. Bruce Montgomery. He's a medical oncologist at the University of Washington who has a keen interest in bringing new innovative therapies for advanced prostate cancer, and he'll be talking about some genomics-based studies. Bruce?
Thanks, Pete, and good afternoon to everybody. I have the great pleasure and privilege to talk to you today about an area that has been getting a lot of press over the last several weeks to months. And many of us have been thinking about this for a very long time. That is what you can call genome-guided therapy, precision medicine, personalized medicine. It's really all about the idea of treating specific people and diseases rather than treating everybody in the same way. And the way that we have been able to leverage this is the amazing advances over the last 10 years in terms of DNA sequencing, because most of what I'm going to talk about today is looking at DNA changes in the tumor itself and how we can do that. So when we talk about sequencing a tumor, there are 3 billion residues that can be sequenced. It used to take a year or more to do that sort of thing. Now it can take several weeks, and the cost is orders of magnitude less than it was just several years ago. So when we talk about sequencing, there are a number of different approaches. I'm not going to go through the details of each of them, but right now most of the commercial assays focus on very specific parts of the DNA that have areas that we know are drivers for cancers, or there is a medicine available, FDA approved, that could potentially treat a tumor that had an abnormality in that area. Oops, that's not what I wanted. So there are examples of tumors in which we use precision medicine even as of today. So leukemias, melanoma, some lung cancers, all of these approaches, that is looking for specific abnormalities in that tumor and tailoring the therapy to those abnormalities, is in common use today. In prostate cancer, we haven't had that really so far. We target the androgen receptor. That's what most of the therapies are really looking at. And most of the other therapies are not specific to molecular aberrations that we know about. They were empirically derived as treatments that worked in prostate cancer, but it wasn't based on molecular characterization. Some of the barriers to molecular characterization that have been a problem in a lot of malignancies are that many of the mutations that we find aren't something that we can actually inhibit for a lot of different reasons, or there basically aren't drugs that are FDA approved and known to be effective against some of the mutations that we find. And in prostate cancer specifically, one of the big barriers has been that when we talk about sequencing a cancer, we're usually talking about looking at either a biopsy or a prostatectomy specimen that may have preceded much of the therapy that men undergo and the tumor is exposed to. So does a primary prostate cancer that's 10 years old reflect what's going on biologically in the cancer today, perhaps when people have hormone-resistant disease, for example? So because these were all significant barriers in prostate cancer, we, in collaboration with a number of other institutions, have been participating in something called the Stand Up to Cancer sequencing effort. So what happens, as laid out on this schematic, is that men agree to undergo a biopsy of a metastasis. That tumor specimen is sent to a sequencing facility. For us, that's the University of Michigan. Those results are then spit out somewhere in the range of several weeks to a couple of months later. And then we have what's called a precision tumor board here, where we interpret those results and return the results to the patient and the provider, whoever that was that referred the patient for this biopsy and subsequent treatment. So this has been going on now for at least a couple of years. And the idea is that we were hoping, and I'm going to show you data that confirms, that we would be able to find alterations that weren't known and find some things that were something that we could leverage in terms of therapy that we have available today. And what I'm going to focus on, I'm not going to talk about all the different things that were found because it's literally a couple of hours worth of discussion, but mostly things that we have found that we now have data specifically from work done under the aegis of the IPCR that demonstrates that we can treat some men's cancers differently with better efficacy than has been done in the past. So this is what's called a mutational landscape or a mutation map of the first 150 biopsies that were done. You obviously can't read any of this at the magnification that you can see, but the point is to make there are some very common mutations up here, some that are common, and some that are very rare. And I'm going to focus really on this specific area because this is something that actually you heard a little bit about earlier from Dr. Chang, something called DNA repair pathway genes. So in the 150 biopsies that were done, 20% of the biopsies had inactivation of these DNA repair pathways in what are called both alleles of the tumor. So these areas were completely non-functional. The tumors were unable to respond to DNA damage in the way that a normal tissue or your standard garden variety cancer would. So these were relatively common, 20%. Of some interest, as Dr. Chang talked about, BRCA1 and BRCA2 are genes that lead to risk of developing cancer. And in fact, half of the men who had these cancers, they also had a germline mutation. So 10% of the men in this biopsy sample had underlying BRCA1 or 2 abnormalities in their DNA. So what is the significance of that? So a little bit of DNA damage obviously leads to cancer development. That's sort of why BRCA1 and 2 abnormalities result in people getting breast, ovarian, and prostate cancer. A lot of DNA damage, which you can induce in a tumor with radiation or chemotherapy, can actually be a good thing therapeutically because the tumor cannot respond to that DNA damage in a way that normal tumors do. And a lot of DNA damage in that tumor can kill it in a way that doesn't happen in the standard garden variety situation. So these are two areas that are relevant to treatment in the near future. So this is PARP, which senses and helps to repair single-strand breaks in DNA. And this is BRCA1 and BRCA2, which are involved in sensing and repairing double-strand breaks in DNA. If either one of these is blocked or inhibited, PARP, there are PARP inhibitors out there in clinical use today, or these are inactivated by mutation, then anything that gives a lot of DNA damage, like radiation or chemotherapy, could result in cell death in a tumor that expresses these abnormalities. Now, the data that I'm going to provide to you is really in the form of case histories. These are patients who've been treated at the University of Washington, and it's mostly to give you a sense that, in fact, we do have evidence that in men who have these kind of cancers, that using drugs that we don't standardly use to treat prostate cancer can be much more effective than what we've been doing in the past. So this was a gentleman who presented with very high-risk disease, Gleason 10, metastatic disease at diagnosis. His biopsy was negative for what's called small cell cancer. We're very sensitized about that here and nationwide. But he developed resistance of his cancer to hormone therapy relatively quickly and developed liver metastases. And because, I'm not going to go into all the details, but I had recommended that he get carboplatinum-based therapy because of the characteristics of his tumor. We did not know the underlying genetics at that time. And he actually went on to receive carboplatinum-based therapy over 2 years, 17 cycles of carboplatinum alone. Actually, when he started to have side effects of the docetaxel, he came back to see us again. Actually, as it turned out, was having more problems with the side effects of the therapy, which he actually recovered from, but had a biopsy performed. Of some interest, this was his family history, which was relatively unremarkable, which will be relevant in a second. And this was what's called Oncoplex sequencing that was done on his tumor. So this was done under the aegis, not of the Stand Up to Cancer effort, but from something that the IPCR funded through Colin Pritchard of the Oncoplex and Lab Medicine branch here at the University of Washington. So this line in the middle is supposed to represent the way the genome is supposed to look. Even expression gains, you're not supposed to have gain, which is anything above, or loss, anything below. In a normal genome, there would basically be a flat line. This tumor was obviously incredibly mutationally active, and the big thing, the most remarkable thing, is he had loss of both alleles of BRCA2 in the tumor. The significance of that is that BRCA2 loss would predict for sensitivity to platinums, which is exactly what he had. He has sensitivity to platinum and continues to have sensitivity to platinum to this day. This is another actual case history without a biopsy to go along with it. It's the first patient I ever treated with docetaxel chemotherapy. Lovely man, developed resistant disease and had metastatic disease at diagnosis. All we had back then in 2004 was chemotherapy. We started that, and he was progressing within 2 cycles, and I added the carboplatinum because for, again, some detailed reasons that I don't think are relevant to this discussion. He went on to have this therapy 3 times during the time that he was here. He actually stopped coming to Seattle because he got so odious. He lived over on the peninsula, and he said, I'm going to continue to respond. I'm going to get therapy over there. He had this continue for 2 more years afterwards, getting exactly the same therapy on an intermittent approach for that whole period of time. Another patient, high-risk disease, resistant very quickly, not small cell, had a liver metastasis, had no response really to, or not a significant response to chemotherapy, was resistant to abiraterone and enzalutamide. We added carboplatinum, and he had 2 very dramatic responses with significant time off of chemotherapy. And when his tumor was sequenced, the same thing was found, BRCA2 inactivation on both alleles of that gene. He also had actually what's called a germline mutation, so the sorts of things that Dr. Cheng was talking about, that is that every cell in his body had this mutation on one arm of BRCA2, and this was his family history. As I'm sure she talked about, you know, we typically think of BRCA2 germline mutations as being associated with high family penetrance of breast and ovarian cancer. He had no history of any of this. So the somewhat, you know, disturbing thing is that that doesn't always predict for the likelihood of somebody having these germline aberrations in their tumor. So what those are supposed to tell you is that we now, when we find these aberrations in 20% of men, have a different approach from what we standardly do, which can be tailored to that tumor, which may provide very significant clinical benefits. And then there are these other drugs, olaparib and ABT888, which are PARP inhibitors that are in clinical studies that we're participating in here to leverage that weakness of the tumor to DNA damage. So in trying to expand on these results, we continue through the Stand Up to Cancer effort to do these biopsies, trying to find new ways of finding weak points in the cancer background. So that effort is ongoing. Locally, we are now, through work done by Dr. Cheng, are developing protocols specifically looking at the activity of specific of this drug in specific mutations for men who have undergone sequencing. We're also looking at how frequent these abnormalities are in men who have high-risk disease, localized disease, and metastatic disease. And I would say, and I'm not alone in this, Dr. Nelson has made this pitch as well, that we really should be talking about whether germline mutation testing should be performed in basically every man with advanced prostate cancer. If 10% of men have this underlying aberration in their tumor, that gives us new therapies to give them, and it has implications for their entire family, since this is an inherited abnormality and risk of cancer. And then the other thing that we're really very excited about is the potential to be able to identify these tumors without doing biopsies, simply by drawing blood and being able to detect these abnormalities in circulating DNA in the blood. So those are all efforts that are ongoing and in various phases of development. So with that, I just wanted to give you, again, a sense of what we're doing here, areas that we think we have available today that from genomic characterization of tumors we can do differently to leverage benefit for patients, and we're going to continue to do it in the near future. So thank you very much.
So our next speaker is Dr. Mike Schweitzer. We're very happy to have him here. He was just recruited from Johns Hopkins University.